This is MetaTherapy, where we talk about therapy itself. Not advice, not diagnosis, just understanding the process so you can use it better. Each episode of MetaTherapy is psychoeducation, not therapy. If something resonates, it's meant to be language you can bring back into your own work.
Let me ask you something. When was the last time you felt truly heard? Not just listened to, heard. Someone sitting with you, present, not formulating their response, half checking their phone, not nodding with that look of, my mind is somewhere else entirely. If you had to think about it, that's already an answer. Most people, when they try to name a moment like that, find it harder than they expected. And that gap between how often we speak and how rarely we feel genuinely received, it's not a small thing. Clinically, that gap is where a lot of suffering lives. I've been thinking a lot lately about what listening actually is, not as a social courtesy, not as a technique, but as something that, when done well, changes the neurological experience of the person being heard. That's not a metaphor. That's biology. Today, I'm sitting down with someone who has spent more than 50 years inside that question, not as a theorist, but as a practitioner, a teacher, a supervisor, and now an author. Dr. David Joseph is a psychiatrist and psychoanalyst based in Washington, D.C. He spent decades training residents at St. Elizabeth's Hospital, supervising analysts, the Washington Baltimore Center for Psychoanalysis, where he serves as president of the board, and teaching George Washington University. And in 2025, he published a book called Listening for a Lifetime, The Artful Science of Psychotherapy. The book is built on 50 aphorisms, short, compressed pieces of clinical wisdom that took 50 years to earn. Things like what it means to hold silence, how transference is not pathology, but creativity, what it feels like to sit with a patient you genuinely don't like, and what to do with that. What drew me to Dr. Joseph's work is the same thing that drives MetaTherapy, the belief that rigorous clinical knowledge doesn't have to stay locked in academic language. That's what happens in a therapy room. The quality of listening, the quality of presence, everything to do with what happens in your kitchen, your marriage, and your relationships. So let's have that discussion. So what drew me to Dr. Joseph's work is the same thing that drives MetaTherapy, the belief that rigorous clinical knowledge doesn't have to stay locked in academic language, that what happens in a therapy room, the quality of listening, the quality of presence, has everything to do with what happens in your kitchen, your marriage, your friendships. So let's have that conversation. Dr. Joseph, thank you so much for joining us on MetaTherapy. I appreciate you being here.
I'm glad to be here, and I'm looking forward to our conversation.
Yeah, me too. So let's begin. 50 years. That's a long time to be doing anything, to be practicing anything. When you sit with that 50 years of listening, what has changed most in how you understand what listening actually is?
I think what has changed most for me in my understanding of the kind of listening that you and I are talking about today is that listening involves one's whole self. It's a very physiological experience as much as simply listening to the words themselves and the meaning of the words. I've come to understand listening as involving my whole self and not just my intellect. And that's change evolved over time, but it's been quite profound in the way I understand what therapeutic is listening is about. And you and I are talking about therapeutic listening, which is different from other kinds of listening.
Sure. But I'm sure that listeners out there who are not therapists could apply some of these same tools and these same. Yeah. Especially in real, I work a lot with couples, for instance, and half of the work is really about teaching how to listen, how to gain perspective from another person. Right. to stop the inner recording going on and to pay attention to what's right in front of them.
Yes, I think that's really hard. I said to someone recently, and it's one of these things where I come up with these little phrases, that the hardest person to listen to is oneself. And when you're really trying to listen therapeutically, or listen, and if you're having a discussion with your wife or one of your kids or one of your employees, is to really open yourself up to hearing how the other person experiences you and how you react to that. And that's, one has to make oneself vulnerable in order to do that well.
Yeah, absolutely. You talk about listening being a body experience. For those who like don't even conceptually understand what that means, can you give an example?
Sure. I mean, one way I think about it is listening to speech is very similar to listening to music. A book I was recently reading talked about the fact that speech is super fast music and music is super melodic speech. And if you think about speech as being musical as well as wordful, music affects the whole brain. Music has this very profound impact. And it means that you open yourself up to hearing the chords and the harmonies, and you listen for what's left out. You don't simply get entranced by the melody of, let's say, the meaning of the words. You can hear, it's like listening to a string quartet. Melody is important, but the other players are equally important. So that's the metaphor that works best for me.
Yeah, I love that. I love that. And I think most people can conceptualize and understand, like, we do listen to music very differently. We kind of allow our, even just tapping or even just kind of going with the rhythm or whatever the case may be is much more of a bodily experience than listening
Well,
to
and
someone
I
speak.
mean, for sure. And absolute, and although aren't aware of it, I
Mhm.
mean, we've got a drum that we call our heart, and it beats at a pretty stable rhythm, and
Mhm.
sometimes it's slower and sometimes it's faster. So from a neurophysiological point of view, we are very, in that sense, rhythmic animals.
Yeah. Absolutely. You wrote this book partly out of frustration with how dense and inaccessible psychoanalytic writing tends to be. As someone who has delved into living, being in therapy in New York City in particular, my therapist is part of an institute. I've gone to APSA conferences and so forth. It's pretty thick stuff. So tell me more about that frustration and why aphorisms felt like the right form.
Well, first of all, aphorisms just kind of came to me um, I had two students and a faculty member that I worked with, and I was a training director as well as an analyst for a long time. And they said, you've got this ability to make these short statements that contain a lot of information. And they were the ones that encouraged me to write the book. But I realized that I came up with these aphorisms because I was so frustrated at how dense and overly wordy, and where the complexity was confusing. And yet, I think psychoanalytic insight into human development, human experience, human relatedness is so meaningful that it's not just that it's misunderstood, it's ridiculed because it's made to seem either way beyond the ability for anybody to truly understand, or sometimes it gets off into just sort of imaginings that are just the average person can't understand. And I thought it was a terrible loss. And so I tried to write something that would be meaningful to my most senior colleagues, but would be meaningful to anybody who's been in therapy or anybody who's interested in what it's like.
That's awesome.
And I've
Amazing.
told people that if there's a sentence in that book that they don't understand, then I've failed.
Right. Right. So you made an effort to make it accessible and make it more understandable and using aphorisms is definitely a very smart way to approach that.
Yes. And the editor that I worked with was not in the field at all,
Oh,
which
wow.
was very, very helpful.
I'll bet. Yeah, absolutely. You mentioned in the book that many of the topics that you cover are rarely discussed in classes or with colleagues or part of training because of shame or because they don't seem substantial enough. What are some of those topics that you felt compelled to name anyway?
Well, it's a good question and one I haven't thought about in this way before. I think it's because it's the times when we're most vulnerable and when something goes on where we do something that is hurtful, not necessarily in a huge way, but sometimes in a huge way to, in this case, we're talking about a patient. The inclination for any of us is, I'm not going to share that. I feel ashamed of myself or disappointed in myself or critical of myself. And I'm not going to share with my colleagues that I want to respect me. And so they get left out. So whether we're talking about what happens if you doze, or what happens if you forget an appointment because you have a toothache and you go to make an appointment with the dentist and leave a patient waiting in the waiting room? Or what happens if you can't remember a patient's husband's name? Those kinds of small things that are just human tend not to be written about, and yet they shape in powerful ways the relationship that develops between a patient and a therapist.
Absolutely.
And I thought it was better to say, come on, guys, let's don't pretend that this relationship is so terribly different from any other one.
Exactly. Some of the work I've had with my own therapist, as an example, has been propelled in large part when those what would otherwise be or seem meaningless interactions, being 5 minutes late and bringing up feelings of like, what did it feel like to have your therapist be 5 minutes late? Like those kinds of things that happens in real life too, right? And so being able to experiment with the relationship with the therapist can be very helpful and beneficial, right?
Yes. And I mean, psychotherapy is first and foremost a relationship. And it's a relationship based on two people whose life developed long before they've met. The way I put it is I was David Joseph for 26 years before I became Dr. Joseph, and 30 years before I became a psychiatrist, and 35 years before I became a psychoanalyst. And that person, with all his foibles and all his strengths, is very much a part of Dr. Joseph. And it's with David Joseph's good points and flaws.
Absolutely. For most people, listening is something that they do with their ears, right? What are you doing when you're listening to a patient? Is it just with your ears? What's the process like for you?
Well, hearing is what I do with my ears. Hearing is what the cochlea of my ear does when sound waves strike it. Listening is what I do with all of my mind and all of my body when the impact of the sound waves is reflected throughout my brain and then has an impact on every aspect of one's body. I mean, when an air raid siren goes on, and I'm aware while we're talking that what's going on in the Middle East, you would feel that in every fiber of your body, right? I feel that when a fire engine goes by.
Sure.
And so listening for me, as I said a little while earlier today, is like listening musically. It's trying to be aware of how the sound that I've heard in my ear, how does that translate and how am I experiencing that in every part of myself? Yes, the meaning of the words, the tone of the words, the rhythm, the tension, the softness. Is there the tone? How often do we know somebody's angry because of the tone? Or so it's trying to understand the way what the person is communicating that he or she may not be aware of.
Right.
That's important. Doesn't mean you're necessarily going to take it up with them, but you're going to want to listen for that.
Sure. Yeah, absolutely. You write about silence as a significant clinical tool, and totally agree with this. But most people in everyday life and relationships experience silence as uncomfortable, even threatening. What's the difference between silence that heals and silence that just makes things worse?
Well, first of all, what you said is absolutely right. Silence is very respectful. Silence is a wordless affirmation of our individuality, of our separateness, of our autonomy. And silence is a neutral experience. One can be silent because one is reflecting. One can be silent because one is afraid to speak. One can be silent simply to take a step back and try to regain your balance. So silence is healing when it gives the other person space and doesn't put them under pressure. But I remember now when you asked me the question that a patient that I had worked with for a long time who had had a horrendously abusive childhood in many ways, they told me that they experienced my silence as feeling that I'd abandoned them if it went on too long. And at the same time, the therapist is wrestling with, well, how long is helpful and how long is my just being present in a withholding kind of way or hurtful. And that's part of the art of being a therapist.
Right. And again, going back to this relationship thing, right? Like if you're the therapist and your client is telling you, I feel like you're abandoning me, then that's a piece of information that comes in to the space, right? And it can be used even as a means for either, depending on what the client's objectives are, to either make them feel safer and or to help them work through that uncomfortability.
Well, yes, and silence is not so much a part of everyday conversation, particularly a long silence, right? If I'm talking to one of my kids or my wife or a friend, and there was a long silence, let's say even 30 seconds or a minute in the middle of a conversation, that would be a pretty unusual thing. Whereas in therapy, often things get tapped into and the patient will be quiet. And it's a reflective kind of experience that they'd like some privacy. And so one has to develop the sense of respecting that, right? Let them create that sense of separateness to do their own processing. But it's not very common in everyday conversations.
That's true. That is absolutely true. Yeah. You've written about psychotherapeutic parenting, and I love this concept because I definitely see this a lot, where you're helping someone grow, develop, become more comfortable knowing themselves. Is that a language uncomfortable for some clinicians? And why do you think it shouldn't be?
Well, the answer is uncomfortable. Yes, I got a lot of grief for the whole concept of psychoanalytic parenting. So we were talking about psychoanalytic parenting.
Yes.
Yes, when I sort of talked about psychoanalytic parenting and psychoanalytic friendship and psychoanalytic love, I got a lot of pushback as though people were only focusing on the love part and not on the adjective. And I don't have psychoanalytic love for all my patients. Some I do, but some I don't. And there's some people that are really absolutely frustrating throughout talk to them. But what it means to me is that this is a genuine relationship. First and foremost, it's psychoanalytic afterward. And parenting doesn't mean, psychoanalytic parenting doesn't mean that I am treating them as though I am a parent or I'm treating them as though they are my child. It is to facilitate, as you said, development and growth and maturation. That's what parenting is about. And the same thing is with friendship. Psychoanalytic friendship is its own unique kind of friendship that exists within the confines of being a therapist and being a patient and having a therapeutic relationship. And it's the same thing with any kind of feeling that goes on. So, but I think it makes many therapists uncomfortable because it's a very intimate kind of concept. It means that we love our patients, we hate our patients sometimes, and it's very personal for them and for us. There's nothing theoretical about it.
Yeah, absolutely. You talk about, speaking of, the unlikable patient, which most clinicians have, obviously, and none will admit. What actually happens inside the therapist when they sit with someone they find genuinely difficult to like?
Well, I can only tell you what happens inside one therapist. That's myself. There's a battle. There's a battle within myself. With the most immediate is David Joseph says, God, this person is really obnoxious. And that's what I experience first. And if I'd met this person at a party, I would decide if I never see them again, fine. So that's the first response one has, at least I do. The second response is, why is this person choosing to introduce themselves in this way to me? Why is the first card they put down, a challenging one or an irritating or an off-putting one? Why do they want to initiate our relationship in this way? And then I begin to think about that as a therapist, not as a person who's not a therapist.
Right.
It's difficult. And there's many people I respect who say they won't work with someone that they dislike.
What's your thought on that?
Well, if they really are so uncomfortable and so annoyed and so irritated by this person and they can't gain a perspective, then they shouldn't work with them, right? The odds of these two people being able to develop a good working relationship is pretty slim. And you say to someone, I'm not the person to work with you. But my recommendation is to sit with it and to try to understand why the person's introducing themselves in this way, and then figure out a way to take it up with them. Because, one way of thinking about it, they're coming to see you because this is the way they introduce themselves to people, right?
That's right. And other people are not going to be, not that I think you rightly are saying that you wouldn't do this early on in the work, but as you develop a relationship, you have an opportunity as a therapist to introduce in a soft and kind way what other people are experiencing. And that in and of itself is huge value for the client, right?
Absolutely. Even if you can say something like, how do you think it impacts me when you come in and criticize me the first thing out of your mouth every time we meet? And that may be something that they'd never really thought about. Or they may say, well, you're supposed to absorb that. You've been well analyzed. That's not supposed to have any impact on you.
I have actually had a client who has said that exact thing. So that's so funny. The other thing I think that happens, and I'm sure that you've experienced this as well, is there's a client that maybe is really rough around the edges and it kind of pushes your buttons as a therapist, but then you start to understand the why, right? You start to develop empathy. You start to go, oh gosh, okay, this makes a lot of sense, right?
Yeah, I think there's always, if we're lucky and tuned enough to the patient, what they're doing makes sense in some private way. It's not not crazy.
That's right.
Right? It's just that the rationale, the understanding isn't apparent to us. Somebody who introduces themselves as an nasty person, it may be a, preemptive strike. I'll be nasty to you before you're nasty to me.
That's right.
And get rid of me.
Exactly. So if somebody watching or listening is not a therapist, just a person trying to be better in their relationships, what's one thing from your work that you would want them to carry away from this episode?
I think the one thing I would want them to take away from is that we human beings need to be listened to. It's part of our relation. It's part of who we have been since birth. And even if you try to imagine what the experience, that's not the right word, but the fetus experiences growing within a maternal body, is that we need to be listened to. And we need to be listened to because when we're listened to, it helps us metabolize our own experience, particularly our emotions. And I tend to think about it in a pretty metabolic, physiological way, that emotions are within us and we're trying to digest them, make sense of them, metabolize them in a way so that we can adapt to them in the most productive way possible. And so we all need to be listened to. And otherwise we just listen to ourselves and then we go down, it's Alice in Wonderland. Then we're down the rabbit hole.
That's right.
And that's why that book is so powerful, because that's what happens when you get trapped either trapped by your own fear of allowing someone to listen to you, or your fear that the way they listen and the way they respond will be hurtful.
Right. All right. So one last question we're going to do this little rapid fire question series at the very end, but one last question.
Sure.
You closed your clinical practice, I believe, at 82?
Yes.
But you have said that you haven't retired your psychoanalytic mind. Can you say a little bit about what that means in your daily life?
Sure. I closed my practice at what I thought was the top of my game because I wasn't willing to gamble anymore, that I would always be healthy, much less be alive. And I'd worked with too many colleagues who practiced too long when they got demented or had malignancies, and there's data about what happens when somebody's therapist just suddenly dies. And then there was a recent article in the Times about that, actually, in the New York Times. And I just wasn't willing to gamble anymore about that. But I was in the middle of writing the book. I continue to teach. I continue to supervise. I continue to write. And what I've had to do is grieve the loss of all that my practicing. No one can take away what I've practiced. But what I've given up is the practicing, which is of giving up something that is meaningful in a new way every day. And that's not replaceable. And it shouldn't be replaceable. I can use the time in very productive ways, but I'm not practicing anymore. And I miss it, but I don't have any regrets.
Right. Wow. So many other questions around that, but maybe for another day. So at the end of our interviews on Thursday Thinkers, we do kind of a rapid fire. So I'll ask you some questions, whatever comes to mind. So first one is, what is, in your opinion, the single most underrated skill in all of psychotherapy?
Being fully present as a person.
Yeah, good. What do you think is the thing most people think is listening, but isn't?
That's a very good question. I would say that what appears to be listening is when the person is simply hearing, that the person is hearing the words, but they're not present in a way that they're experiencing the other person in a full way. And so it feels, at its worst, it feels hollow and it feels inauthentic. In more subtle ways, it feels this person doesn't really want to know and experience who I am in the moment, what I'm going through. And yes, they're they're hearing and they appear to be listening, but it's very shallow.
Right. They're maybe faking it, or yeah, I mean, there's all sorts of degrees of this, right? It's like on a dial, so to speak. But yeah, I think
I wouldn't say they're faking it, because they may be, but it may be that they've not learned to listen differently.
Right. That's true. Yeah, that's a good one. If you're willing, the best piece of clinical advice you've ever received.
The best piece of clinical advice. The best piece of clinical advice is one I got in medical school.
Okay.
And I can remember the time well. I was in a stairwell at my medical school, and a hematologist, I can picture it now. He stopped me in the stairwell. I don't know, we were leaving a conference, and he said, "You know, David, when you make a diagnosis, you stop thinking." And that's never left me, because it's really said, keep your mind open. You know, it's related to go to meet every patient expecting to be surprised, or without start each session without memory or desire, so that you can really be open to receiving something totally unexpected and to think something unexpected. Otherwise, our wish to have order and certainty will block us from knowing what we need to know.
Absolutely. I think that's great advice. I think any kind of label is dangerous, right? Putting people in a box limits what we believe about the human species and the human experience.
Yeah, I think psychiatric diagnosis is a very dangerous tool. It can be very helpful, but it can then easily morph into experiencing our patients as having an illness rather than wrestling with human problems. And even if someone has, I mean, look, we know lots more about the physiology and neurophysiology of severe mental illness. And I believe that illness is a real concept but what is illness and what are problems in living, and how do you distinguish between the two of them? That's a very challenging topic. And I think if we think about our patients as having an illness, then they're sick. And that's a very different kind of relationship.
Exactly. Often, and this may not be perfect, but I often will say to clients that, in my view, diagnoses are for two reasons. One is for research, the grouping of symptoms, the grouping of things, and to understand a little bit better what happens there. And the other is for billing, for insurance, for healthcare purposes.
Yes, and I think it is helpful to think of the quote illness aspect of someone's stressful experience. What's illness? But on the other hand, most of the kinds of suffering that humans go through has to do with being human, not with being ill. They may be more vulnerable to getting depressed when someone they love dies, or they may be more likely to get incredibly disorganized or psychotic when they're threatened because of genetics or neurobiology. They're first and foremost a person who has become suicidally depressed.
Right. Last question. The aphorism from your book that you find yourself returning to most.
That's the one. Somebody asked me that, and that's one that I can answer because someone asked me that not long ago.
Okay,
but in a very different context, not about the book. And this is for me personally in terms of my development, and that is that people will like you for doing a good job, not for being a good guy. That's been personally very important to me because I'm somebody who avoided disappointing people. But it's allowed me to do many things that are the most caring things I can do, but they aren't very pleasant to me, and they're not very pleasant for the other person. And most recently, it's come up actually just today. where I've had to talk with a colleague who's gotten severely cognitively impaired and is still practicing. And to be able to go and talk with him about that is the most caring and concerned thing I can do, even though he may experience it as my being aggressive. And for me to realize I'm not being aggressive, I'm simply being assertive because
Right.
he can't be assertive for himself. And so that's played out in all aspects of my life, not just professionally.
Wow. Dr. Joseph, thank you so much. This has been wonderful. I really appreciate the time you've given. Can you, for our listeners, can you let folks know where they can find your book, where they can find more information about you?
The name of the book is Listening for a Lifetime, The Artful Science of Psychotherapy. It's published by Mission Point Press. Any of your local bookstores can order it. I mean, if they order it, it won't come through Amazon, and there are plenty of people who are boycotting Amazon, but you can get it on Amazon, and Amazon has the ebook. I would love to hear from anybody who reads the book and would like to share what their reactions are, because as we talked about earlier, I've tried to write a book that will really be meaningful to anyone who's interested in the topic. And my email address is dijoseph@gmail.com.
Thank you so much again.
Well, listen,
And
I was going to say, I very much appreciate your inviting me. It's been a privilege to talk with you and indirectly with your listeners.
yeah, me too. We are as well. So for those listening, I'll have the link to the book and the other information that Dr. Joseph just shared in the show notes. And whether you're a clinician, a therapist in training, or someone who wants to understand the person in front of you a little bit better, it's definitely worth your time. And if this conversation resonated with you, share it with someone. You want to listen to you better. Sometimes we have to teach each other what we need. My name is Dominic Adori, and this has been a Thursday Thinkers episode of MetaTherapy. I'll see you next week.